In this lecture, we'll be going over the definition and the diagnostic criteria for malnutrition. This criteria was determined by the American Society for Parenteral and Enteral Nutrition, as well as with the Academy of Nutrition and Dietetics. So the simple definition of malnutrition is any nutritional imbalance. This could be too much nutrition, such as overnutrition that we see in obesity, or also too little nutrition, undernutrition, and the related diseases. However, there's been an agreed upon consensus that when we say malnutrition, what we really mean is undernutrition. So that would be the too little, inadequate nutrition. The Aspen and A&D said that the definition in their paper, the overarching definition, is decline in lean body mass with the potential for functional impairment at multiple levels. And these levels include molecular level, the physiologic level, and or gross motor level. So the impacts of malnutrition. This is kind of why professionals are focusing so much on malnutrition. It greatly affects many aspects of healthcare and society in general. Malnutrition is associated with increased morbidity and mortality, meaning that people who are malnourished are more likely to develop certain diseases and then be more likely to die from them as well. The presence of malnutrition during treatment can delay wound healing. It can increase risk for infections as well as complications. And it also can cause delayed convalescence, meaning it takes more time to recover from the illness. This leads to requiring more intense and longer treatments and increasing the patient's length of stay in the hospital. As a result, the patient's quality of life, as well as the family or caregiver's quality of life, declines, and it causes an increase in costs at both the individual and societal level. Therefore, malnutrition is an important condition that we need to be able to identify and treat. Malnutrition typically occurs along a continuum of various factors. Intake level is one of the first things to check for any patient because energy and nutrients come from that food intake. If someone's food intake is inadequate, eventually we will see the negative impacts on their health. Inadequate intake can be combined with increased requirements at times, and when this happens, it increases the gap between nutrient needs and the amount supplied. Organs not functioning properly may cause impaired absorption or impaired transport of the nutrients. Sometimes they may be intaking adequate nutrients, but there is some condition in the body that is making it so that these nutrients cannot be used as they normally would. So either the person does not have adequate amount of energy and nutrients available at intake or at the level of metabolism. Either way, the body does not have enough to function and therefore malnutrition will occur. When malnutrition is present, we usually see the presence of inflammation, hypermetabolism, and or hypercatabolism. Note that there are no actual inflammatory markers proposed to diagnose malnutrition. They are just markers for inflammation and not malnutrition. And we'll go over this a little bit more in detail. In the past, there wasn't really a standard consensus of diagnostic criteria for malnutrition. That's why Aspen and A&D collaborated to develop this new diagnostic criteria. According to the Evidence Analysis Library, what is still commonly used in the clinical setting are changes in acute phase proteins, such as albumin and prealbumin. These markers do not actually consistently and predictably change with weight loss, calorie restriction, or nitrogen balance. Although clinicians still may use albumin below 4.0, for example, as an indicator for increased nutrition support, we have to be very clear that the scientific evidence so far indicates that these acute phase protein markers are better indicators of the patient's severity of inflammation rather than their nutritional status. And speaking from experience, you will definitely see physicians diagnose different levels of malnutrition using markers such as albumin. Due to the limitations of these markers, Aspen and developed etiology-based malnutrition definitions. Often, the decline of these serum markers are one of the last things to happen, and they don't really tell us the root cause. So the new diagnostic criteria digs down into the etiology of what is actually causing the malnutrition. So here we have a kind of a decision flow chart we'll go through. And, when we first approach a patient, if we remember from the NCP process, before the nutrition assessment occurs, there is actually a nutrition screen, which can be done by any healthcare professional. It doesn't have to be a dietitian. This is often done by nursing in acute care settings, where they'll be asking the patient a lot of information, and part of it deals with nutrition, and that is where the nutrition screening is done. If a patient is identified as being at nutritional risk that could lead to compromised intake or loss of body mass, especially lean body mass, we as dietitians need to be alerted of this. And this will usually happen when the nurses mark certain boxes. It'll automatically alert us to a consult through the electronic healthcare record. Or if the nurse or doctor thinks that they're at risk and maybe they didn't quite make those things to check off on, they'll go ahead and order a dietitian consult for us to come see the patient. So once we're seeing them, we would then assess if the person is already malnourished or if they're at risk for developing malnutrition. The next question would be, is inflammation involved in the condition? So we can use this decision-making flowchart to answer a series of yes or no questions and go into the direction depending on the answers. So if we answer to if inflammation is present and we answer no, then we can conclude that this person's malnutrition is a result of starvation. So the cause is pure chronic starvation, such as famine, or the results of conditions such as eating disorders like anorexia nervosa. There are no other factors related to malnutrition in this case. It is just due to the absolute inadequate intake. And that would be in contrast to something that's a disease condition that might be increasing their requirement needs. So that's not the case in this. It's just pure inadequate intake. Now, if we answer yes to inflammation being present, we have two directions we can follow. And we need to kind of check if it is severe or not severe. So if we answer that there's a marked inflammatory response, that would be an acute disease or injury. And this would be something such as a major infection, a burn, trauma, a head injury, something along that. And that these things will often increase needs for the nutrition requirement. Now, if we say it's a mild to moderate inflammation, this is likely due to chronic disease-related malnutrition. And so this is where our immune system is consistently launching inflammatory responses, but not quite to the severity we see in acute accident injury like burns. So this slide here kind of gives us a summary of the etiology-based malnutrition definitions. And we can see here the 3 etiologies: starvation, chronic disease-related malnutrition, or acute disease or injury-related malnutrition. Here we'll go over the specific diagnostic criteria for malnutrition. And given the complexity of malnutrition, we do not have one single marker to check as we would in, say, hypertension, where we could just measure someone's blood pressure. And if it was higher than 140/90, then we can say that they have hypertension and use that as our diagnostic criteria. The etiology-based definition of malnutrition requires more of a checklist approach to reach diagnosis. This checklist contains these 6 items, and we have to check and see if they have any or all of these. So we want to make sure and go through this with each patient. And if the patient has at least 2 of these 6 characteristics, then they are malnourished. So we'll go ahead and go through each of these. The first one is insufficient energy intake. And this is really where the dietitians come into play, because the intake domain is really in our scope of practice. So we'll want to be, seeing their recent intake history as well as how they're doing in the acute care facility. The next is weight loss, which could be unintended weight loss or maybe a dramatic weight loss within a short period of time. And kind of going with weight loss, there could be the loss of lean mass and subcutaneous fat, both of which can contribute to the weight loss. And this makes sense because a long-term indicator of energy balance is body weight. Also, localized or generalized fluid accumulation may sometimes mask weight loss. So we can say, maybe the patient weighs the same as they did last month, but, they kind of look a little different. We might be seeing their lower extremities with a pitting edema. So even though they weigh the same, we can deduct that their body mass has actually decreased, and the difference in that weight is made up by their fluid retention. We see this often in patients with congestive heart failure or people with liver disease or chronic kidney disease. And then if we remember, we also wanted to look at functional impairment at the molecular, physiological, and or gross motor levels. And this 6th feature here, characteristic, allows us to do so. Current evidence supports the use of hand grip strength to see if a person has functional impairment, as this test is not likely to be affected by other factors that happen to be present with malnutrition. So definitely memorize these 6 characteristics and know that it requires 2 or more of them to be positive in order to diagnose for malnutrition. We can see here the first one It's kind of more like the intake domain. These ones through here are more, the weight loss, loss of muscle mass, loss of fat, or fluid accumulation. We're more looking at the physical assessment domain. And then the last one here, we have a functional test. Notice that this does not involve any lab test. There's no markers that we're looking at, no albumin, no prealbumin, no CRP levels. We're not looking at serum vitamin levels to look for nutrient deficiencies. That's not how malnutrition is diagnosed. So luckily, this list is pretty easy to apply, and a lot of this information we can get from things that are probably already inputted into the patient's chart before we even go see them. So we'll notice that these 6 characteristics are continuous. They happen along a continuum. We're looking at weight status, fluid retention, and impaired intake, which can vary hour to hour, day to day. Also, you'll notice that the etiology-based diagnosis of malnutrition distinguishes between severe and non-severe malnutrition. However, there is no distinction between mild and moderate malnutrition. Notice that they were grouped in the same category on the flowchart. And also, we'll want to check the patient for these characteristics at each encounter, especially those that are high risk. So, of course, the initial assessment, when we first see them, at frequent intervals that will depend on the patient's condition, how often those are, and then also after discharge. So if we're incorporating the NCP model, we're looking at monitoring and evaluating the patient and making sure that it's documented in their record. Malnutrition can be diagnosed, or the criteria for it can be noted by different members of the healthcare team and then entered into the electronic healthcare records. And it's important that everyone documents this or somehow gets these things communicated in order for everyone on the team to be on the same page. For instance, the nurse or CNA might be the first to recognize an intake impairment when they go into the room or go to pick up the food tray and notice that nothing's been touched. This should be considered in the doctor's formulation, and since they, especially in the state of California, the physician has the privilege, they would be the one that actually documents the diagnosis for medical billing. We definitely want to document it in our notes, but also make sure that the physician is documenting it as well. And then, as we mentioned before, they need to be monitored at intervals throughout the stay and after the discharge. We are the qualified nutrition personnel as the food and nutrition experts, as dietitians. So we need to make sure that we are seeing these patients and that we're following the NCP model. Be aware that sometimes malnutrition diagnoses may not be reached on our first encounter with a patient, as we need to count at least 2 positive characteristics for malnutrition. This could be if the patient is maybe their condition is deteriorating and they're developing malnutrition, but at this time of the assessment, they do not have at least 2 of the positive features. So we should note that they have signs of developing these characteristics and are at risk for malnutrition and try to intervene. There are examples in the position statement, so please read these. And, remember that patient conditions changes along a continuum, but we as RDs may encounter them only at specific points in time. And so we need to be aware that the patient is at risk for developing malnutrition in order to make sure that we are monitoring and evaluating for that at each of our visits. With acute onset, which may occur with trauma, the patient could be in a coma or intubated. Maybe there's no friends or family around, no caregivers. So we have no way to really assess what the patient's intake was like before the trauma. And we also might not have access to the weight history to determine if there were any weight changes. Also, edema may form later on after our initial assessment, and so we wouldn't be aware of it at that time, and this can kind of pose a challenge to document malnutrition. In other cases, we need to look critically at the information provided by both patients and caregivers. We know that there's a psychology where people want to please medical professionals, so they may tell us what they think dietitian wants to hear. Caregivers for the chronically ill or elderly may provide modified information, and this is because they don't want to be perceived as not doing their job well or starving the patient. And we know that elderly are more prone to be malnourished, and caregivers definitely don't want to be told that they're doing a bad job. I mean, a lot of caregivers are family members, and they don't want to hear that haven't been taking good enough care of grandma and that she's looking skinny and malnourished. Really just be aware of this. You may have to ask different questions or seek the information elsewhere to make sure that it's accurate. We also always need to consider the progression of the disease. As I mentioned before, in the beginning, the patient may not meet the diagnosis criteria, but as the condition progresses and it runs its course, they may then develop some of the characteristics to meet the criteria. This is especially with when massive inflammation is occurring. You know, it can limit the effectiveness of nutrition care, which would contribute to the development of malnutrition. There might be certain medical procedures and medications that affect the nutrition status. Should be such as intubation, where there's no oral intake, or they're having many procedures done, which is also negatively affecting their nutritional intake. Critically ill patients, especially the elderly, are at high risk for developing malnutrition on admission. We need to pay special attention to their ability to eat. They may not be able to eat much or anything at all. We need to investigate and document their feeding regime, including nutrition support, and always check their weight history. So just to go over interruption of enteral or parenteral nutrition, usually when the nutrition support prescription is written, it is for a 24-hour infusion. But some RDs, when they're calculating the actual infusion amount, they'll only count 20 hours because the tube feed is often stopped when the patient undergoes certain treatments, like breathing treatments, or if they're having procedures done and have to be taken out of the room to go down to the lab. And although it's written as a continuous infusion, it commonly does not stay on for the total 24 hours. And this, you'll kind of get to be a better judge for yourself as you gain more experience with patient care. A lot of the pumps now have features where you can go and check how much of the formula has been given in the past 24 or 72 hours. So you can see if they're getting the majority of it or if their pumps have been turned off frequently, and then go ahead and adjust your recommendations based on that. So with all these dynamic factors, it's important to monitor those who are critically ill to see how their nutritional status is changing. As already mentioned, in certain etiologies of malnutrition, inflammation plays a big role. Although the markers do not tell us accurate information about one's nutrition status, it does tell us information about the inflammatory response. For example, if a patient had an acute injury and after a few days, the markers show that the inflammation has decreased, this is a sign that the original trauma is being treated and the inflammation response is not as severe as it once was. In this case, the patient's nutrition support would have better outcomes because the nutrients would be used for more towards recovery rather than supporting the severe inflammation response. We should assess this closely and communicate with the healthcare team in a timely manner. So back to this etiology-based malnutrition definition and the decision-making charts. We do need to collect a lot of information when we are making this diagnosis. Looking at the history and clinical diagnosis, whether it's a long-term condition like a renal patient, or if it's acute trauma, as if an athlete just got into a car accident. For physical exams and clinical signs, we're going to want to look if the feature in the diagnosis criteria is weight loss, lean body mass, or subcutaneous fat loss. And also we want to look for fluid accumulation. And all of these would be part of the physical exam findings. Remember that there are no lab values involved in the diagnosis of malnutrition. However, lab data that we mentioned could be useful for checking inflammation status and not looking at the nutrition status directly. Weight history would follow under the anthropometric data, and we'll want to look at the intake domain as well as the functional assessment, which would involve the hand grip strength test. So to summarize, although when you're out in a clinical setting, you may see practitioners still saying that because there is low albumin, the person needs more nutrition support, we need to know that this is not correct in order to actually diagnose for malnutrition. We need to use the latest criteria to diagnose 2 out of the 6 characteristics to diagnose this. And, if you're seeing in a facility that you're working at that there may be a group of doctors or a doctor specifically that's incorrectly diagnosing malnutrition based off of inflammatory markers, you can talk to your clinical nutrition manager and perhaps do an in-service for some of the physicians, or ask if they would like some more information on how to appropriately diagnose for malnutrition. There's a couple different ways you can do it. Since we are the nutrition experts, we want to be sure to share our knowledge with the other healthcare team members so that we can all be on the same page and this can be diagnosed correctly. Therefore, we'll want to memorize this criteria. When we come across a case, we can easily determine if we want to diagnose the person with malnutrition and also what it's caused by. And just a reminder, the 3 etiologies are pure starvation, chronic disease, or acute trauma or injury.